Okay. Hi, Eva Kosek, and thank you so much for agreeing to do this interview. Would you like to maybe introduce yourself first and your research just in general terms and your way into researching fibromyalgia?
Okay, so my name is Eva Kosek and I'm professor of clinical pain research at Karolinska Institutet in Stockholm, Sweden, and also at Uppsala University in Uppsala in Sweden. And I'm also a pain clinician, so I'm a specialist in rehabilitation medicine and pain relief and work with patients. So about my research, I was one of the very early, I guess, researchers. So I started my PhD on fibromyalgia in the 90s and defended a thesis 96 on fibromyalgia. And then, of course, I continued doing research, and I now have two research groups. Basically, my research is focused on understanding why people develop pain and why they develop fibromyalgia. So very much about mechanisms, and we work with a lot of different methods. So we look at mechanisms in the muscle, but also, for example, doing imaging studies and looking at how the brain is processing pain stimuli and so on.
That's very interesting. How did you get interested in this specific group of patients?
So for some reason that I really don't know, I was always interested in pain. I think it's because pain is such a multifaceted and very interesting topic, since it spans over what you would call the body and also the mind. And when I started with pain, I realized that muscle pain was a very, very common problem in the pain population. And so there were a lot of, well, not a lot, but there were some researchers working with muscle pain, but then you had a group of patients who had actually muscle pain in nearly all their muscles, and those were the fibromyalgia patients. And nobody at that time where I was really doing research on those patients. So I thought this was very interesting, because how come that they have so widespread muscular pain? And so I became interested in fibromyalgia, and of course that led from muscle to the central nervous system as well. So yeah.
So we were very interested when we heard about, I'm going to say the new, although it's not very new, but the new pain definition, nociplastic pain. And I was wondering, how did that third type of pain come into your work and the work that you've been doing with the IASP?
Yeah, so I have been struggling, and not only me, but for a very long time, with the fact that large groups of patients' pain were classified as pain of unknown origin, although we knew that there was a lot of dysfunctions in the pain processing. And I thought this was disturbing, and I didn't really know what to do about it. But then the definition of neuropathic pain, which is pain due to lesions or disease in the nervous system, the definition was changed from disease or dysfunction to lesion or disease, and the dysfunction was left out. And that made it, I think, very evident for a lot of researchers that there is a need for a term for the patients who have a dysfunction in the nervous system regarding to pain processing. And so a lot of terms came up, like centralized pain and pathological pain and what have you, and they were not defined, and it made, well, it was a chaotic situation. So when I started on the council for ISP, I also became engaged in the terminology task force that I led and chaired. And I thought that this was a task that we really should take on, to try to define a new pain category for those people where you know that there are severe dysfunctions in the processing of pain, and yet they are not explained by, tissue injury, which is we call nociceptive pain, or the disease lesion in the nervous system, which we call neuropathic pain. So that's the story. And then, of course, we worked together, the whole terminology task force, first on defining a term and then on the criteria for nociplastic pain manifested in the musculoskeletal system.
So it was,
sorry.
No, go.
Now, I think this is very relevant for fibromyalgia because fibromyalgia would be a prototype of a nociplastic pain condition. So, yeah.
Yeah, exactly. That's why we were just so excited when we saw that there was actually some terminology that made it more clear what was actually happening in the body. So this whole work with the terminology, it happened from the ISP group of terminology trying to define a third type.
Yes, that's correct. So the ISB terminology task force worked on this, on the term and then on the clinical criteria. That's correct. And it also fits well with the new classification of diseases, that is the ICD-11, where most of the nociplastic pain conditions will fit into the primary pain, where the pain is seen as a disease of its own, in its own right, and not just a symptom. And that is also, I think, very important to explain to people that pain can actually be a disease and not only a symptom, meaning that you have to address the pain as such. And you know, sometimes the pain you cannot get rid of by treating more peripheral causes. Yeah.
Exactly. That was actually my next question. So did this nociplastic pain came from the work of ICD-11, or
no,
was it just like in general this idea about pain being a disease on its own that led to both?
You could perhaps say the latter. So it was a work in parallel. So the nociplastic pain, it did not at all come from the ICD-11 group, but those two task forces were working in parallel, you could say. And it's not synonymous in any way. So nociplastic pain is a pain type, it's a mechanistic descriptor, whereas the other one is a diagnostic code. And also in the primary pain, you also have actually pains of unknown origin. So it's not all about nociplastic pain. But the notion that pain could be a disease of its own, I think, came in parallel in both of these. Yeah.
Was there, I don't know if you know this, but was there consensus in the pain environment about the necessity of adding nociplastic pain definition?
So, I mean, it's hard to, so we sent out the proposal to a lot of experts, and I think it has been very well received by most. Of course, I mean, we haven't asked all of the pain society, and certainly there are also critical voices, absolutely. So there has been some debate about this. But I think, so most of the clinicians and the researchers that I meet are positive. There are some, especially, I would say, perhaps the older generation of neurologists, they are sometimes not very happy with this.
Okay. I mean, there's, I guess, always some discussions about changing terminology.
Yes.
That's been there for a very long time.
Yes. But I would say that some of the people, at least, that have objections are maybe not the ones that work a lot with syndromes like fibromyalgia, and may also not perhaps, some of them have perhaps not read the latest research and so on as well. So, but of course, there are also very knowledgeable people who disagree. I don't want to pretend otherwise. That's always the case. So.
Yeah. So what have the consequences been of this new terminology, or will be?
So it's as I said, is the term nociplastic pain has, I think, been very well received. I've been contacted by researchers and clinicians actually around the world. The criteria are translated to various languages and so on. I think the consequences are potentially many. So first of all, by recognizing that this is actually something that we know something about, that is a pain condition where we know something and understand something about the pain mechanisms and what has gone wrong, gives some more credibility to patients. And also, I think for patients, it's important because then, so, I mean, if I have a patient and I say, okay, so we would classify your pain as pain of unknown origin, but we still know a lot about how to treat it, I think that is a little bit harder perhaps to accept than if you can say, okay, so you have nociplastic pain. We know that nociplastic pain has these and these criteria, and there are these and these symptoms, and also these mechanisms that do not work properly, and therefore we recommend the treatment such and such that would then help with this and this. It makes much more sense, I think. And the notion that it could be a disease of its own right, I think it's extremely important, because both in research and in clinics, sometimes pain has been treated as just a symptom. And if you deal with the underlying condition, then the pain will go away. Now, we have understood that this is unfortunately fairly often not the case. So, I mean, 30% of OA patients still have pain following even hip or knee replacements, for example. About 20 to 30% of patients with rheumatoid arthritis develop fibromyalgia, and so on and so on. So I think it's very important to focus on this, and thus also give resources to clinics working with these kinds of pain, and also research, of course.
Yeah, because there could be more interest from research groups into this specific type of pain, nociplastic pain, or maybe even funding to do research.
Yes, I think so. I hope so. I should say, however, that I mean so mechanistic research in fibromyalgia has been there is a lot that has been done. So the research interest, I would say, is large, even in preclinical studies, because fibromyalgia, so animal models of fibromyalgia have been regarded as models of dysfunctional pain inhibition and so on. So the interest there has been fairly large, but perhaps in the clinical setting, a little bit less. And at least in Sweden, I know that a lot of fibromyalgia patients really, really struggle to get the healthcare that they would benefit from.
Yeah. Do you think that this new terminology could also help the clinicians in diagnosing?
Yes, I hope so. I hope so, because so diagnosing the pain type is relevant, especially, I would say, for pharmacological treatments. And so the nociplastic pain is fairly similar when it comes to drug treatments or pharmacological treatments to neuropathic pain. And the important thing clinically, I think, is that we know that a lot of patients start up with a more localized nociceptive pain, and then in time develop a nociplastic pain condition. And there you might need to change the pharmacological treatment altogether. For example, opioids are not indicated in nociplastic pain conditions, and most likely can even make them worse. So by making clinicians to think about what type of pain is this, you help them to choose the right pharmacological treatment. In some ways, actually, also the right physiotherapy, because in nociplastic pain conditions, a lot of the endogenous pain inhibitory mechanisms are dysfunctional, which means that physical exercise has to be it's still beneficial to do, but you have to perhaps the dosing of the physical activities has to take this into account. Whereas I would say for psychological treatment, pain type does not matter. I mean, if you have a depression and anxiety, it doesn't matter if it's because of neuropathic, nociceptive, or nociplastic pain. So there, I think it's less important.
Who do you expect would be responsible of kind of sharing the knowledge about this terminology national?
Well, that's a good question. I guess that depends on which country we talk about. So the Swedish Medical Products Agency, I think it's in English, Läkemedelsverket, they actually use the term nociplastic before ISP even approved of it. So it's in the guidelines of treating non-malignant chronic pain. So, I mean, that is one example. Then, of course, all the universities and so on, where you teach about pain. So that is part of the curriculum. The EFIC, for example, which is the European Pain Association, had a so during the yearly, or it's every second year, but never mind, congresses, they also have refresher courses, and they teach about these different pain types and so on. So I think it's ongoing, but I guess it differs slightly between different countries who takes the responsibility. Yeah.
You said that the terminology has already been translated to a lot of different languages. You know,
so I mean, the ISP, of course, it's in English on the website, and it's not that complicated. But I have been contacted by people from Asia and so on, asking me whether it's okay. And of course, it's okay. I mean, it's publicly available, right? So, and that goes for the clinical criteria of and grading of the nociplastic pain that is manifested in the musculoskeletal system.
Yeah.
Nociplastic pain in viscera, hopefully there will be criteria as well, but those have to be developed by a task force consisting of experts in visceral pain, obviously.
As you mentioned also before, I would like to just quickly talk a bit about the differences between Denmark and Sweden in regards to fibromyalgia. So in Denmark, we do have some issues with the patients waiting a very long time before receiving the diagnosis. And I imagine that maybe you have a similar situation in Sweden?
Yeah, so the last figure that I saw, but it's quite old, but it took 8 years on average to get the diagnosis. Hopefully it's better today, but I really don't know. So I personally think that we currently have a disadvantageous situation for pain clinics in Sweden. A lot of them have been forced to close. So I think the situation is actually getting worse for chronic pain patients in Sweden than it was like 10 years ago.
Okay. How about the treatment? Because I mean, of course, we have also some pain clinics, but long waiting lists, and there's not really a one treatment that works very well.
No, so that's right. I mean, there is no single treatment that works very well for all patients, but there are certainly treatments that are efficient and sometimes very, very efficient for some patients. And for some patients, you have to combine different treatments. So to me, the problem is a little bit that, at least in Sweden, there is, now we are talking politics, but there is a tendency to say that, okay, so we have to have a specialized clinic that could investigate and set the diagnosis and then come up with treatment recommendations, but all the treatments will be in primary health care. And please don't misunderstand me. Of course, I mean, these are very common pain conditions, and most of them have to be diagnosed and treated in primary health care. That is obvious. But we should not forget that some of the fibromyalgia patients actually are very, very severely ill. I mean, fibromyalgia is, if you look at the quality of life, for example, it's a condition where you have really bad quality of life and a high degree of suffering for the patient and the patient's family. And of course, those patients need very specific and high quality treatments. And to me, it's a little bit like saying, okay, so let's say we have these surgical conditions that are very common. So we will have a surgeon diagnosing, and then he or she says that this is an appendicitis or, gallbladder or whatever common cause of surgery. And so the surgery can be performed by a primary care physician. Of course, then you say it's the surgical wards and so on, but that's not the point. The point is that in order to become a good surgeon, you have to perform a lot of surgeries. And in order to become good at treating severe chronic pain, you have to see a lot of patients suffering from severe chronic pain. And if you are a primary care physician, you see a lot of different patients, so you never get that experience. So to me, it doesn't make sense. It's just like everybody could treat, and that's not true. Not when it comes to complicated, severe cases. So actually, when I talk about fibromyalgia to patient associations and so on, it's really sad, because after the talk, there is always like a sea of people asking where should I go, and what should I do? And I don't know what to tell them, because really there is they have very few alternatives, I would say.
Exactly. I mean, it's the same situation in Denmark.
And I think one of the important things that actually patient organizations could and should do, and I know that a lot of them are doing it as well, is to talk about this and to talk with politicians and healthcare providers about this, because I think hopefully the patient organizations will be more listened to. If I say it, everybody will tell me that, well, you're talking your own interests, so we don't care what you're saying, basically.
We try. So lastly, I would like to talk a bit about fibromyalgia research in general, and maybe also a bit in the future. So in your opinion, what are the most important trends in fibromyalgia research now and in the next maybe 5 to 10 years?
Well, of course, everybody's closest to themselves, and so in collaboration with Professor Camilla Svensson at Karolinska Institutet as well, and some other researchers in UK, for example, we have found that there seems to be an autoimmune component that matters in we think not in all fibromyalgia patients, but perhaps 40-50%. And to me, that is really, really interesting. And that is what we are pursuing now. Camilla in more preclinical models where she can look at mechanisms, and my group in patients to see how we can link the levels of these specific autoantibodies to symptoms and various pathology in fibromyalgia. We can see that patients with severe symptoms have more of these antibodies, so there is a positive correlation there that we know already. But now we try to find out in patients what are the mechanisms that explains this. To me, this is very, very interesting, because that would open up, and of course we are also looking for the antigen, that is what the antibodies are. We know what they bind to, but we still don't know exactly the chemical structures that they bind to. So of course, in order to make big assays that could be clinically available to then diagnose if there is an autoimmune component or not, there is a lot of work still to be done. But I think if we can identify these patients in a good way, then current immunomodulatory treatments could then be used for these patients, which would be a totally new strategy. And also, of course, if we understand more about the mechanism, perhaps we could also develop totally new biological targets to treat fibromyalgia. So to me, currently, that is absolutely the most thrilling and interesting issue right now. And I mean, we are not the only group working on it. There are several groups, of course, internationally doing that.
It sounds very interesting and promising with the correlation that you found.
Yes, to me, it's so since I'm a clinical pain researcher, to me, that is always very interesting, because that tells me that maybe, we still don't know, of course, the causality. These are just associations, but we see that patients with high levels are those that have more symptoms. And when I say symptoms, it's mainly actually pain intensity, not so much the other symptoms of fibromyalgia, which also makes sense to me, because what we see in our animal models so far, these antibodies actually increase the signaling in the, so professionally we would say primary nociceptive afferents, which means that the first sort of nerve cell that would transmit the pain signal to the spinal cord. So it makes total sense then that these antibodies would correlate with pain intensity in the patients. So yes, it is very promising, but we'll see.
If you can only mention one thing, what do you hope that we know about fibromyalgia in 10 years?
Perhaps that we would be able to subgroup patients with fibromyalgia into different, mechanistically now, so that we can target, this is in a way ridiculous to say, because that's what everybody says. We need individualized treatments for pain, and that's basically what I'm saying, but for fibromyalgia. But I think really that is a key issue.
That would be extremely helpful to be able to do that. That was all my questions. I want to say thank you again. This has been very interesting, and I'm sure that our members will also enjoy all of these informations. It's been very, very interesting. So
thank you, and thank you for the work that you do as an association. That's really important.
Thank you.
Yeah.